Ashri, and good morning, everyone. In today's academic session, we are conducting Journal Club. We are discussing a few papers published by our Indian authors, and those papers are really worth reading because they can impact our practice. And today we have three eminent panelists. Dr. Anil Agarawal from CNBC Delhi. Couple of papers are his, and thank you, sir, for sparing time. Dr. Jayanth Sampath from Bangalore, our own colleague and chief editor of Journal of Pediatric Orthopaedic Society India, and Ashish Ranade from Pune. Ashish, welcome. So we will take growth modulation papers first because Dr. Anil Agrawal has to leave earlier. And the format is we'll discuss the paper, the fellow will read, and then once we are done with, we'll discuss the intricacies and the doubts. So Kunal, can you share the presentation? Yes, I think now we can do it. Good morning, Jayanth.
Morning.
Good morning, everyone. My journal club presentation is on two important papers by Anil Agarawal sir. Can we make out the coronal plane correction of the region by studying the screw divergence in tension band plate induced growth modulations? It was published in Journal of Pediatric Orthopaedics in May 2025. It is a retrospective study with the level 3 evidence.
Kunal, could you just speak up, please?
Yeah, can you be louder?
Yes, sir. The hypothesis of the study was the change in the screw divergence noticed at the follow-up varied in the proportion to the degree of correction of the coronal angular deformity. Am I audible, sir?
Yes.
Okay, sir. The aim of the study was to determine if the screw divergence could be used as a substitute for limb alignment films when monitoring guided growth, and the divergence effect of the epiphyseal screw on the angular correction.
Sir, your body, sir.
Or the correction can use between the screw trajectory angle and the correction achieved could be measured. The another paper that was published in 2024 November was hemiepiphysiodesis using tension band plating and the influence which insertion technique or the screw length influence on the rate of correction. It is also a retrospective study with level 3 evidence. Hypothesis for this study was change in initial screw trajectory angle, inter-screw angle, distance of the screw from the physis, and the length of the screw. Will that affect the angular correction rates of the tension band plating while treating a coronal plane deformity of the knee? The methods used for both the papers was the growth modulation was done between January 2020, 2011 to December 2021. And the radiographic records were obtained with the preoperative weight-bearing radiographs, and post-operative radiographs was taken up immediately after post-op. The final radiographs were taken at 1 year or adjacent to plate removal time. The exclusion criteria included that inadequate radiographic records or additional procedures used in conjunction with the growth modulation. The measurement studied from the radiographic records was by two important characters: screw trajectory angle, which is as shown in the figure, is the angle made by the screw at the time of insertion in the plate, and the inter-screw angle, that is the angle between the two screws, measured approximately at the immediately after the post-operative X-ray. The length of the screw was taken as a percentage because of the adequate approximate evidence of the length of the screw was taken. And the distance of the screw from the physis was also calculated. Preoperatively, the lateral distal femoral angle was also measured, and medial proximal tibial angle was also measured. The results were as such that 28 children were included, and there were 68 physes that were operated in this period. The average age was 8.6 with a standard deviation of 2.82 years, ranging from 3 to 12 years. The average follow-up time was 12.1 months with a standard deviation of 4.8 months. Bilateral deformity was found in 22 children, and 11 children had combined procedures, with the 7 children having both the limbs operated simultaneously. This was the distribution of the uh, plates used, which was 19 plates were used in tibia, 49 were in used by femur, and the sex distribution was females were pretty common that they were 1:6 ratio between the same. The males were 1 and the females were 6. The pathological distribution was such that 20 patients had post-rachitic deformity, while idiopathic were 5, skeletal dysplasia was 2, and Poisson's deformity was seen in 1 patient. After this, the interscrew angle was initially 18.9 degrees with a standard deviation of 10.3 degrees, which changed to 35.9 degrees with the standard deviation of 14.8 degrees. The mean screw divergence change was 17 degrees plus with the standard deviation of 10.2 degrees. The correlation between the degree of correction and the screw divergence showed a negative correlation, and the p-value was 0.1797. Sorry. For femur, the correlation was found that it was 0.16 with a p-value of 0.28. For tibia, the correlation was other negative part was part correlation with the mild negativity of 0.09 and a p-value of 0.71. The true screw trajectory angle was initially measured as 13.5 degrees with a standard deviation of 8 degrees, which changed to 23.8 degrees with a standard deviation of 11.5 degrees. The mean screw trajectory change was 10.5 degrees with a standard deviation of 8.4 degrees. Correlation between the degree of correction and screw trajectory was negative 0.11 and the p-value was 0.36. For femur, as they were calculated for separate bones, for femur it was positive 0.27 degree, 0.27 positive correlation, while the p-value was 0.056. For tibia, it was negative 0.35, and the p-value was 0.14. The various measured parameters in the series was the age varied from 3 to 12, and the mean was 8.6. The correction rate achieved was 1.1 degrees with per month, with a standard deviation of 0.6 degrees per month. The screw trajectory angle was 13.4 degrees of mean with a standard deviation of 8 degrees, and the interscrew angle was 18.9 degrees with a standard deviation of 10.3 degrees. Distance of the screw from the physis was also calculated as a percentage, 37.2%, with a standard deviation of 17.8%. The length of the screw was also calculated as a percentage as in proportion to the length of the physis. It was 41.3 degree percentage, and standard deviation of 9.7%. The correlation between the rate of angular correction and various parameters were studied. With the child age, it was a mild negative correlation of minus 0.13 degrees, and p value was 0.3. The screw
Which were the significant correlation? Just tell that, Kunal. So the child age was not a significant, screw trajectory angle was not,
None,
interscrew angle was not. So what was positive?
none was significant, sir.
None were significant. Okay, fine.
Yeah.
Yeah, go on to the next slide then.
So
Go on to the next slide. Yeah, this is a comparison.
yes.
Yeah.
So now the discussion is about what the strong correlation between the screw divergence and joint orientation was hypothesized earlier in a paper by Maragos, sir, in 2017.
Mm-hmm.
But we couldn't establish it in the present study. The hypothesized that divergent configuration of the screw reduces lack of correction and latency period in correction by Stevenson in 2018, but it was also not justified in the study. The biomechanical study showed no difference in the screw length or plate size. And also the divergence range from 0 to 30 degrees didn't have any effect on the angular correction rate as established by uh, L. Sir.
So what was the observation in this study? Whether the screw length, Anil sir, whether screw length make any difference or not?
Sir, it was a retrospective study. So
Hmm.
when we perform a procedure, we always see that we always follow the previously issued guidelines. The initial guidelines were that we will not use a very short screw. So in none of the case, the screw size was less than 40%
Right,
compared to the 5C size. When
right,
we compare this parameter and the variations nearby, then the screw size did not have any effect on the correction rates. So it has that our minimum size of around 40% compared to the 5-6 length was always present. So the result had to be interrupted with this background in mind.
right. So
A
in the
short screw will always cut off.
okay, because that will come out as the correction would improve. You
Yes,
know, if
yes,
the plate reaches maximum or optimum divergence, then the plate will come out.
yes.
So
So
what
there
is
is,
your yeah
please,
yeah
sir.
yeah Kunal, you can get through and then we'll discuss further points. Yeah.
Yes, sir. Sir, in the further slide, our interpretation for the Article 1 was that the screw location and the trajectory angulation does not influence the magnitude of angular correction. The screw divergence hardly correlated with the angular correction, and the screw divergence and angle measurements are unreliable, and the correction based on them might not be as effective. More complex
Hmm.
process by plate deformation or biological factors is at play when studying the growth plate modulation. For Article 2, we studied that the interscrew angle may be resulting in narrow screw angles may correct faster rather than the large angle interscrew angles. Age has a negative correlation, so the older children may have less growth potential. The screw distance from the physis, the more the distance, less is the compression, as there is negative correlation. Length of the screw, more robust is the fixation, more is the compression, as there is a positive, mild positive correlation. So the strength of this study is that it has a robust database, or it has a good sample size of 68 cases. Only Genu Valgum cases were included, so we don't have to undergo any discussion about the bias of the rate of correction in the Genu Valgum and the Genu Varum. And the limitations of the study would be the retrospective study. It did not consider variation in the physeal growth rate with age, and the precise screw material, screw length, plate size could not be considered, and no different plate for tibia or femur, as there is difference in the contour of both the bones. So the takeaway message from that I learned was that tension band plate is not just a mechanical tether, but a complex biological phenomenon at the physeal end.
Right. So, Jayanth,
So Kunal,
Yes, sir.
the purpose of a journal club is not to read papers. Anyone can read papers. Purpose of a journal club is to understand how to read papers. Yeah,
Yes,
the
sir.
methodology, learn the methodology of how to critically analyze a paper, right?
Yes, sir.
So you said that in your slide, you said if there is a 1 degree increase in screw divergence angle, there is
Yes.
0.5 degrees rate of correction.
So that was postulated in a paper.
Okay,
But
but again, it agrees with the findings of the study, right? They got 30 degrees of screw divergence and 15 degrees of correction, right? So on the face of it, there are clouds in the sky and it rains. If there are no clouds in the sky, it will not rain, right?
yes,
So there is a correlation between clouds and rain. Okay,
yes,
so
sir.
screws are diverging and the leg is getting straighter. Okay, so why does this study, when we all know the obvious fact that when screws diverge, the leg goes straight? You've seen that, haven't you?
Yes, sir.
So why does the study say that there is no correlation? They're saying, it can rain when clouds are not in the sky, and when clouds are in the sky, it can rain. Is what the
so
conclusion of this paper
so
is. There
what
is no correlation.
Jayanth mentions
So
is
explain that.
Kunal.
Explain why.
Yeah. So what he's saying is, what was the hypothesis? Whether hypothesis was true or not, and on what basis it is proved, right, Jayanth?
Correct.
What is the initial?
So you have to critically analyze and explain why the authors, or is there a problem with the powering of the study? Was it a well-powered study? So you have to analyze the strength of the paper to say, are the conclusions made by the author valid or not, in your opinion? I can read this paper and I don't need your help to read the paper. I can read English, right? So
Yeah.
you're supposed to critically analyze the paper, right? So that is the purpose of the journal club, not to just read the paper and just put up a few slides. That is my comment. Yeah, that is my comment. Is you have to critically analyze what the authors have done, not just to present the paper.
Right. So I agree, Jayanth, and we didn't have time. I didn't have much time to go through the presentation in details, but this is the first journal club, so that is okay. Now, do you have any question regarding Anil? What was your inference of both these papers?
So the two papers are from the same data set.
Yes.
Okay. So in the first paper, the later paper, we have this lot of children undergoing growth modulation. And when we call them at 4 months follow-up, okay, so we have to obtain a scanogram to monitor things. The scanogram is a rare modality still in our hospitals, and it's also a costly affair to the parents as well as the family. So suppose the treatment lasts around, say, 16 months or 15 months. So that means approximately 4 scanograms, one pre-operatively. And so the paper was that, can we do a regional X-ray? Because we know that the divergence is related to what Dr. Jain pointed out, that the divergence of the screw is correlating with the limb alignment. Okay, so can we have, like we obtained for a fracture thing, can we obtain regional X-rays instead of a full limb alignment X-rays? But in our study, we found that although there is a divergence, but the divergence does not directly correlate with the changes in the limb alignment. Okay, so towards end of the, you might get the X-rays, regional X-rays intermediately, but when you are doing the fine tuning in the last, when you want to decide regarding the plate removal or anything, whether the full correction has occurred, you need to have a scanogram. It's not a mathematical model.
So
Like,
if you changed this into a categorical variable, yeah, rather than a continuous variable of whether there is, just give an yes or no answer. Is there screw divergence?
yes,
Okay?
there is a full divergence.
No, so what I'm saying is redo the study statistically and make screw divergence into a categorical variable and make
Yes, sir.
clinical measurement of correction into a categorical variable. Clinically, are you seeing an improvement? Is the leg straightening?
Yes.
Make those both into two categorical variables and correlate. You will find an extremely strong correlation between the two.
Yes, there is, sir. This we always observe in
Like
clinical practice.
the R value will be like 0.9,
Yes.
it will be something like that. So we
Yes.
know that when screws diverge, the leg becomes straight. Yeah?
Yes.
That's all we need to know. Because I don't do routine scanograms. I do scanograms only when I am very close to removing the plate.
Yes.
Right.
That's the
So
message we are giving, sir. That's the
Yeah.
message we are giving.
But I don't think there will be a mathematical and arithmetic
formula.
correlation between screw angle and the rate of correction. So that depends, as I agree with Kunal's assertion that biological factors are obviously involved and this is not just purely a mechanical process. So I agree with what Kunal said in his last slide.
Yeah, so similar practice, we clinically check the child, and when they reach near once they reach a little overcorrection, we get a scanogram, make sure the mechanical axis is passing one zone. There are sometimes instances we see that the correction is not happening as expected, and there we want to see whether there is optimum screw divergence or not. So that was the inference of your second paper. And what is the inference of first paper?
Yeah. So we always have been told that put the screws in divergence. Okay, slight divergence. Do not converge them. And there has to be a specific size for the screws. Thirdly, that the screw has to be placed not too close to the physis, not too far from the physis. If you put towards the edge, then you have to use a longer plate. Okay, so in this particular study, it's again a retrospective data. What we did was that we checked these parameters to the rate of correction. And I've already told you the limitations that we have always used a screw size approximately 40% of the physis. And we have put the screws never too close to the physis, but there were slight variations which we picked up in this study. So again, this study showed that the divergence of the screw length compared to the physis width and the distance from the physis does not actually make an impact on the correction rates, limb alignment rate. As far as they are reasonable, the plate works, provided it is done in a reasonable manner.
Right. There is some question.
It's a very forgiving implant, is what you're saying.
Yes. I remember when Peter Stevens took a lecture in Sick Kids in 2008. He came for on, and then Will Cole was the chief, and we were asking a lot of technical questions, and Stevens said, "You just put it. You raise whatever soft tissue, you put it, and it will give result." So that's right. So there's some question.
Yeah, that's not to say that we should not exercise due caution. I have seen very badly done 8 plates that do not work. So
we have seen the screws migrating from one side to the other, especially in the dysplasia patients or rickets. So of course, but as you said, it's a forgiving implant. Now the question on the chat box is, what's your view on its effect on undulated physis? I think
that's it.
That's a theme, right?
Undulated physis,
That
we are routinely using. So we have measured the horizontal distance, and this study was not related to this undulated physis. We put the implant like a classical manner.
Yeah.
Does that matter? Sometimes I wonder, this is a question I have. So in very young children in the femur, you can see that the medial slope and the lateral slope is quite high. So you actually
Yeah,
have to put the plates at quite
little
an
high.
oblique angle to the joint line.
Yes.
I've always gone parallel to the physis, which is upward. I have to put it at an upward
Yeah.
angle. Is that what you do, or do you try and put it like straight
At
to the
at
axis of the
least
limb?
at least the epiphyseal screw stay to the physis. Metaphyseal screw can be divergent, sir.
Mm.
But I never try to converge towards the physis.
No,
Yeah.
I have
So
put convergent screws and they have worked. I mean,
yeah.
it's not that you should not, but I think as far as possible, parallel screws, I think is parallel or
Yeah.
slightly more.
Parallel or little distracted. That's what Peter Stevens say.
Yeah.
Why he say you don't put in convergent fashion? Would it do compression
Yes.
across the physis?
No,
Yeah.
though, sir, try to understand the lever. When
Hmm.
we do the convergence, the screws axis meet far away from the plate, from the screw divergence. When the screws are divergent, there they meet, try to imagine an extra articular line, extra physeal line. So
Hmm.
the ends converge near to the area where you require the correction. So
Correction.
like the deformity correction principle, the farther is the your manipulating force,
Okay.
the longer it will take. So that's
Ah. Yeah. Got it. Got it. Great. So thank you, Kunal, for reading that paper, and thank you, Anilji, for your inputs.
yeah.
Preksha, can we discuss the next paper,
Yes, sir. Can I share my screen?
please?
So is it visible?
Yes.
Good morning, everybody. I'm Preksha, and I'll be presenting a paper on midterm outcomes of shoulder dislocation. 1 second, sorry. In brachial plexus birth injuries treated with injection botulinum toxin A. It was published in Journal of Pediatric Orthopaedics in 2025. It's a retrospective study carried out at a tertiary referral center, and it's a level 4 evidence study. So what was the aim of the study? Evaluate the midterm outcomes of injection Botox in the internal rotator muscles and identify the factors determining the outcome of the procedure. So what was the method? So it was the retrospective data collected between 2011 to 2022. So hospital of sick children active movement score was recorded at every visit, and it was a scale to measure the improvement. Passive external rotation was measured with the infant and supine position. So what we practiced here was axial shoulder ultrasound was indicated when passive external rotation was less than 60 degrees in any of the follow-ups. So there were 86 children initially counted in the data, but 10 children underwent nerve surgery, so they were excluded, and 14 children were lost to follow-up. So the final data accumulated was of 62 children, and they were followed up for a mean of 36 months. So the dose, 2 units per kg body weight, was given to subscapularis and pectoralis major. So here we are depicting how it was done for subscapularis. So 23 gauge needle is bent in the center for about 60 degrees. Then the arm is forward flexed and internally rotated. This makes the medial border of the scapula prominent, and needle is inserted at the undersurface of the scapula. Then it is withdrawn a little bit so that the needle end stays in the bulk of the muscle. And in pectoralis major, what we do is we divide it into 4 quadrants, vertical and horizontal line intersecting at the nipple, and 2 needles are inserted each in the clavicular and the sternal head of the pectoralis major. So what is the position in which the manipulation and closed reduction is done? So lateral position, arm abducted, elbow flexed to 90 degrees and forearm supinated. The manipulation technique, thumb stabilizing the humeral head posteriorly. Arm is passively externally rotated to at least 60 degrees and humeral head reduce. So what we feel is the humeral head reducing into the glenoid. So this position is held for 5 minutes to stretch the anterior capsule and soft tissue. The spike up position, so the abduction of 30 degrees, external rotation of 60 degrees is maintained and the spica is continued for 3 weeks, post which a nightly splint is given to the patient and physiotherapy is initiated. So our results, average age was 11.5 months. The average follow-up period, as mentioned earlier, was 36 months, and the outcomes were divided into 3 groups. Group A, which consisted of 27 children, did not require any further follow-up or surgery. And group B was 27 children, 40, that is again around 44%, shoulder rebalancing procedure for recurrence of internal rotation contracture. And group C was 8 children, developed external rotation contracture and had difficulty in reaching midline. So we'll get into the details of each group. So group A, as I mentioned earlier, did not require any further procedures. So they had higher elbow flexion and abduction than those of like children in group B and C. But there was no difference noted in pre-injection passive external rotation or any other parameters or even the aggregate scores. Group B, in which shoulder rebalancing was done for recurrence of internal rotation contracture. So in this, we observed that the passive external rotation improvement in passive external rotation was there, but there was no active external rotation. And they developed an arm internal rotation posture at an average of 6 months from index procedure. So what we say is inadequate C5, C6 recruitment indicated by poor elbow flexion and shoulder abduction compared to group A. And in group C, that is external rotation contracture and difficulty in reaching midline. So as I mentioned earlier, 8 children were in this group. 6 had difficulty in reaching the midline, but 2 could reach the midline by wrist flexion. So this is commonly tested with hand to belly. So out of the 8, 6 of them required arthroscopic posterior capsule release. So this was basically C7 involvement, which was noticed with weak triceps and wrist dorsiflexion compared to the other 2 groups. So so other studies which had, the other authors which conducted similar studies. So Ezaki et al. They studied 29 children and concluded that 11 children required secondary surgeries. And we say that 44% in our study, but they did not consider a common starting point, but we conducted ultrasound diagnosis in every patient to establish that there was subluxation and Botox was given for the same. So Michon et al. And Prince et al., they concluded that Botox produces benefits which are sustained beyond active period, which we have also said in our study. So this was given adjuvant to tendon. So in their studies, they gave it adjuvant to tendon transfers. But in our cases, it was done as a standalone procedure. Arid et al. Studied effect of Botox in patients who underwent prior nerve surgeries, and 68% did not require further muscle rebalancing surgeries. It was inconclusive as a reason of improvement can't be attributed to either nerve surgery or Botox. Greenhill et al. Studied 49 children, concluded that pre-injection passive external rotation was the most important determining factor. And they said that passive external rotation more than 30 degrees prior to the procedure, adequate recovery and avoidance of further procedure. But in our study, we say that higher shoulder abduction and elbow flexion as a positive correlation. So this is the summary for which I would like to elaborate. So group A, as I mentioned earlier, did not require any further surgery. So they had good recruitment of C5 and C6. So when internal rotation contracture is treated, good external rotation, which is sustained over time, Then in group B, so poor C5, C6 recruitment, that is low shoulder abduction and elbow flexion. So when treated, they developed good passive external rotation, but no active external rotation. So they redeveloped arm internal rotation posture, and this required further shoulder rebalancing surgeries. And in group C, which had C7 involvement, which was depicted by weak wrist dorsiflexion and triceps, when treated, developed an external rotation contracture. So children with C7 involved, Botox given to subscapularis weakens the internal rotator, thus leading to external rotation contracture. So we should always treat patients with C7 with only close reduction and spica application, and Botox should be avoided in these patients. So what's the limitation of our study? It's a retrospective study. No control group who underwent only manipulation and spica application. As I mentioned earlier, that in C7 involved patients, we should avoid giving Botox, and it's an effective method when there is early recruitment of C5, C6, and it can avoid surgeries in about 40% of patients. Thank you so much.
Yeah, so Jayanth, your comment again, like Jayanth would say that we are here to, assess the way the paper has been written rather than reading the content of the paper, but I think they would learn, Jayanth. I remember through all the fellows and trainees, when I was in Sikkids, we were doing a journal club on classification of Perthes disease, and Bob Salter was just sitting beside me, and they discussed all Herrings and Salter Thompson and all. And at the end of journal club, that in Sikkids are there all epidemiologists are there, so they torn off the papers like this. They all classified are rubbish, and I got so shocked that Bob Salter, the primary author, is just sitting here and they are just staring off the paper that none of the classification is robust and they have all fallacies. But that's the way they train their fellows and trainees to read the paper to the deepest. Now, Preksha, what you have done is you have read the paper, how it has been written. We all want you to read between the lines. And I would have been happier that if you have shown that these are the limitations of this paper. I know what are the limitations. Anyways, but this paper gave us an idea that which are the candidates where we should not use Botox, at least. Ones with lack of wrist dorsiflexion or weak triceps. And one more thing which we now see is volume of subscapularis on MRI, which we don't get done routinely in infants, because they need another anesthesia. So this was the paper where all the patients have ultrasound diagnosed the dislocations. And so we had a uniform starting point, and we done the uniform intervention, and then we have seen till 5 years that which patients required intervention. One limitation is many patients from our eyes, we would think that this child has limited terminal elevation, limited external rotation, a bit of trumpeting, but those families think that, oh, this is fine for our child. So the endpoint decision is becoming on patient base rather than a surgeon base. But what I felt is ultimately we do surgeries if the parents are willing to, and so we chose those patients who opted for surgery, and some of those where I have suggested surgery and they have yet to be recruited for surgery. You understand, Jan, what I mean?
Yeah. So no, we're all recently, me vicariously through my assistant, we've all got your latest brachial plexus thoughts. So about the paper, Preksha.
Yes, sir.
What is the biggest criticism, if you were to criticize this paper, what is the biggest limitation of the paper?
Mhm.
Single, what is the most important limitation of this paper? So it's an intervention study, right?
Yes, sir.
Yeah. So if you have an intervention study, what is the first thing you need? You need a
Ethical clear.
no. You need a
Control group.
Control.
you need a control group.
Yeah.
So you don't have a control group, right?
Yeah.
So the authors have basically intervened in everybody. So you don't know what is the natural history of the problem. If you left it alone, what would happen? So then you need to say, okay, if you didn't do anything at all to an infant with shoulder dislocation, what happens to that shoulder? Do we have data about that? We
Yes.
know we do have data about that. It results in a bad outcome. So ethically, it's not correct not to intervene on an infantile shoulder dislocation. So you have to do something. So once you have decided, okay, I'm going to do something, then you look at the options. So as mentioned by the authors, just putting them in a shoulder spica may have worked just as well. You don't know, right?
Yes.
So, and that is mentioned by the authors in the paper. It says our limitation is the lack of a control group. So that is the biggest criticism. So it would be important for trainees to understand. So what is the second limitation of the study as published, right? What is a second? So we are trying to find gaps so that we can do further studies in the future which are better than the published study. That is the whole purpose of doing a journal club. The second is every study should have a power analysis. Yeah.
Yes, sir.
First thing you need to know, because type 2 errors are very, very common in orthopedics, and this is a well-established fact that all the studies are underpowered. That all our orthopedic studies are underpowered. So doing a power analysis based on previous data, looking at effect size, those things are extremely important when you want to do a good study, particularly a study with large numbers of patients. If the authors had just done a small power analysis in the statistics and shown that their study is adequately powered, done a power analysis, then I would have had even greater confidence in the validity of the results. So those are my two comments about this particular.
Yeah, so that is right, Jayanth. And we have done this study because if we see the three variables of whether they need surgery or not, subsequent surgery, or whether they develop different deformities. So based on that, the power was good, and there's the largest series published in the world, But if you look at the multiple parameters, then you may find that there's suboptimal power. Secondly, the control group, so we see lots of patients. Of course, this is the limitation. What we did in MISR paper, we took a historic control. Unfortunately, we do not have historic control for untreated brachial plexus palsy. You show me one paper that they will study that this infants coming to us, they have contracture and we have not treated. We have our own database where there are patients where I have advised Botox in infancy. They then come default and they come at 2.5 years. And then we have suggested now you need soft tissue release and rebalancing. And now they have come at 8 years and they are Waters 5. So we have those.
I think that's a very important paper to publish, because then you have good natural history data to say that untreated brachial plexus in infancy has a poor natural history. I think that's very important to establish, because I don't think it'll happen from the West. Someone like you has to do it.
So I could saw such two patients during this course. I did 2 osteotomies, and both those patients were advised intervention in infancy, but they didn't undergo, and then they later ended up with a very non-congruent glenohumeral joint. And so my observation is Botox helps in halting the glenohumeral joint deterioration. So that also we studied in earlier cohort of patients. So that is one. Secondly, we have treated few patients with spica and nothing in injection for now in C7 group of patients. What I have seen that if they do not have good recruitment, they behave they are their external rotation, relaxation, internal rotation lasting very less time, and we do not have much time for the external rotator to recruit and see. Some of those patients have required to do casting twice, to keep them again relaxed for some time and see whether they recruit. So I know that Botox and casting works better than isolated casting or isolated Botox and splinting and no casting. But once you have seen poor outcome, mine is a private center. How can I create controls? I mean that is, if I would always choose a surgery which I will do for my own child. So that's a limitation of the study now. But we are looking if something we have advised and patient has not undergone and they come to us later. We have a few such cases, not a very big database, but that will be a good study. Great. So let's move on to the last paper, and I will invite Ashish to present that paper. I was also part of that study, and this was a nicely conducted Delphi survey. And we all practice Genu Valgum correction. So Ashish,
Yeah,
you can
thank
share.
you. So, yes. Okay, so thank you. Good morning, everyone. So, briefly, I'll discuss this international consensus on management of idiopathic genu valgum. So, why this study? So, this is the commonest scene, right? We see genu valgum in our clinic across the ages, and always, at least I am in dilemma. What is the best way to treat across the ages? So, the decisions are based on all these factors, but there are lot of gaps. There is limited evidence for clinical evaluation protocol. Do I base my decision only on intermalleolar distance? Do I use the flexion test and decide? There is no standardized approach for surgical intervention. When do I remove the growth plates? Where should the axis be? Should I be doing X-rays every 6 months, 3 months? Just clinical evaluation is sufficient. Again, how do I decide between pets? So lot of unknown things, and same goes with osteotomy types and fixation methods. So decided to do a Delphi because it may not be possible to do a randomized control trial, the gold standard for every these problems. So Delphi gathers anonymous expert opinions to reach consensus, and it helps to develop some guidelines. I agree that this is based on personal opinions and level 5 evidence, but it could be a start to answer some of the questions. So, sorry. I'm sorry. I don't know why it is not forwarding. Okay. Yeah. So, three PDPods and one public health specialist, we worked on the questions. We invited 40 experts. 29 people responded. Fairly experienced, with majority of them were practicing limb deformity practice. And we decided consensus as 70%, two-third, one-third. We divided the survey into four: history, six statements, physical examination, radiographic investigations, treatment, and follow-up. So 46 statements, we did 2 rounds. Uh, After second round, we reached some conclusion. So the key findings were there was unanimous agreement that we want to know whether the deformity is progressive or static. We want to evaluate the pain. We should obtain a standing full-length radiograph with patella forward position while evaluating. And common peroneal nerve decompression should be individualized, which means it should not be done in every case. Then also the consensus was reached that it is important to obtain uh, the standing X-ray and measure the mechanical axis deviation and joint orientation angles. And X-rays like patellar skyline views, they need to be done when indicated, not in every case. Then it was recommended that surgery should be recommended when mechanical axis is in zone 2 or beyond on the lateral side. And at least there is 2 years of growth remaining. But the panel could not reach consensus. How do we decide that? How do we decide the growth remaining is 2 years. The panel felt that tension band plating, 8 plate, is the preferred modality for children less than and older than 10 years of age, irrespective of age. Then for follow-up, monitoring every 3 to 4 months before implant removal and every 4 to 6 months after implant removal is recommended. For older children, the panel thought that one should remove the guided growth implants when the mechanical axis returns to the center of the knee. Regarding common peroneal decompression, the recommendations were anonymous that perform common peroneal nerve decompression if you are doing acute opening wedge correction of more than 20 degrees. Do not perform peroneal nerve decompression if you are doing gradual deformity correction for any magnitude, if you are doing acute opening wedge correction less than 20 degrees, or if you are doing acute closing wedge correction less than 20 degrees. Despite of this survey, a lot of questions remain unanswered. We could not reach a consensus. When do we do bone age assessment and what is the best way to know it? We gave them 4 options: the hand X-ray, elbow X-ray, the knee X-ray, and the Grulich pile method. So the big question remains, how do we determine the growth remaining? Then the panel could not reach consensus. What is the treatment when growth remaining is less than 1 year? The child is close to skeletal maturity. Then timing for implant removal in younger children. Should we achieve overcorrection or we do when it is in center of the knee or when it is through zone 1 on lateral side? There was no consensus. Again, no consensus on management of rebound deformity. There was no consensus on type of optimal osteotomy in adolescents, whether you should do closing wedge, lateral, opening wedge, or angulation translation type of osteotomy, or a dome osteotomy. And then there was no consensus for doing, if you are doing an acute closing wedge correction of more than 20 degrees. So those are the statements without consensus. So a lot of things still remain unknown despite of this survey. So limitations were, since idiopathic genu valgus is mainly femoral, we did not ask about tibial osteotomy and indications for peroneal nerve decompression. And then there are certain limitations due to the design, because certain questions may not be framed and certain data remains unanswered. So future directions, we need multi-centered pooled data and high quality prospective studies. The areas I feel might be growth potential determination methods, evidence-based recommendations about implant removal after guided growth, and various comparative techniques for determining the best osteotomy type. So take-home message, in my opinion, from this paper will be: use mechanical axis, not intermalleolar distance, for surgical decision-making. Tension band plating is preferred for guided growth irrespective of age. At least 2 years of growth remaining is necessary for growth modulation, but how to determine that remains unknown. Regular follow-up is crucial to prevent over-under correction. Common peroneal nerve decompression should be selective based on specific indications. And remember, consensus guidelines provide a framework, but still gap remains. So much more work needs to be done. Thank you.
So thank you, Ashish. And if I can ask you, would you change anything in your existing practice based on this paper? So what are those things?
Yeah, so routinely I used to do lateral x-rays of the knee. But then in this study, a lot of people felt that there is no need to do lateral x-ray. So I never looked at whether there are associated sagittal deformities with idiopathic genu valgum. Maybe that study I would like to do, but um, yeah.
Yeah, so most of these studies, we see a lot of observations, but when it comes to application to our practice, most of people they continue what they have been doing. So anything specific came that would impact your or
So
the common
I
practice?
My takeaway point from this was pets for older children is still debated. I would stick to 8 plates.
Yeah.
That was one point. Common peroneal nerve decompression. There are specific indications. If I'm doing opening wedge more than 20, then only I will do. Then bone age determination is not necessary in every child. So
Yeah.
specific indications, but we could not reach consensus. What are those? But we agreed that it's not needed.
Yeah. That's right. Yes, Jayanth, your observations?
So this is a great study because idiopathic Genu valgum is a condition we understand very poorly, and we get all sorts of outliers. So it's good to frame the problem. I think Ashish, for the first time, I think in the literature, has actually framed the problem in a very systematic way. So the questions are now coming out from. I think it's an important first step in terms of proper scientific, following the scientific method of framing the problem on a worldwide basis. And then now you get the questions from the Delphi survey. But also I'm reassured as a surgeon that what I am doing is roughly what everyone else is doing, which is also very important for us as surgeons, particularly when you deal with an unknown condition like Perthes. You don't know the etiology of it, so you're always on a little bit of a shaky ground. Things like Perthes, sometimes even DDH. So idiopathic Genu valgum is one more of those conditions where when the family asks you, why did this happen, you just tell them, I don't know. It's some factor in the growth of the child that causes this. So when you deal with such conditions, I think it's important for us to do studies like this, Delphi surveys, and hopefully we should pool our data and start to understand this problem better. I personally do overcorrection of the mechanical axis, and I do PETs. So again, that gives me good feedback as a surgeon that many other surgeons are actually not overcorrecting. They're actually going to the center of the knee for plate removal, because I have seen cases of rebound. Did the study address this? Because they have said center of the knee. Did you address this problem of rebound?
Briefly, we did, but we didn't go too much into it because then if we have too many questions, the panel doesn't respond. So
Respond.
already we had 46. So we stopped there because yes, that's a very important, but maybe a different study.
No, it's a
One of
very
the
interesting
question,
paper.
yeah. One of the question would be when you have judged the residual growth and you have done growth modulation and you have not got the growth, we see that those things uh, very frequently now. Younger children getting maturer and the menstrual age does not correlate with the residual growth as well, because we have endocrinologists in house. So even the lateral x-rays, sometimes you see very tiny opening of the olecranon apophysis and still they keep on growing. The renal pathologies, they keep on growing for longer time. So we need to be more, in some patients, we just do procedure to bring them into zone 1 and to avoid major surgery, and they correct completely, and they sometimes overcorrect. And some younger children, they don't correct at all, and then families are fight. So I think the calculation of residual growth is still not, there's the parameters we are using are really approximate and they are not full. What do you think?
I don't think with growth remaining, I don't think we will ever crack that problem. It is just so many factors,
Yeah,
genetic, environmental, dietary, just so many factors that I don't think it's a problem that is so easily cracked, by which we'll get some investigation modality that will just
right.
so there's another one that is rotational assessment. I think that's very important because many a time with the idiopathic Genu valgum, I do find that they are in a little bit of antiversion,
Yeah,
and I do tend to do a little bit of derotation when I do my osteotomy in adolescents. So that would have been another thing to address. I
yeah,
thought.
And another question, like the terminology which we use, older and younger. So we tried to define that, but again, that was very difficult. It's very difficult to have a cutoff, whom you call younger, and so that's, I understand it's a very generalized statement, but as Jayan said, we cannot give a pinpoint answer to.
Right.
So
All right. So
my,
growth
my final
model.
remark, Maulin, is
Yes.
you said we have in-house endocrinologist, but I also have an in-house pediatric endocrinologist, but your meaning is completely different. It is like in my house.
Yeah. No, she is not endocrinologist at home. Okay. She is the chairman. Okay. Right on.
Very good.
Yeah. So thank you, and thanks for your input and time. And you sound like a true Posy journal editor. So good. Good. And I think we need to have one of the sessions how to assess a paper for
Yeah.
all the trainees, and why it is important, because not every published paper is, we have seen in JBJS or JPOA also, the papers have very poor biostatistics, statistics analysis, and then so we must train our colleagues to how to read a paper, and don't blindly rely on whatever is published. That's
I think you
what we
should
need.
get a good epidemiologist from Sick
Yes.
Kids or something like
Yeah.
that and conduct maybe even
How,
2 or 3
to read a
sessions.
paper. Yeah.
Yeah, how to read a, it's very important. It's very important. That it's a generic skill that we should all have.
Yeah.
Yeah.
And once
And
you know how to read, then that will also make you stimulate you to write a paper in not in hassle but in a good study,
and
that will be of help. You are spending so much time on it.
and
Yeah.
to add to this, we fortunately had someone in designing this study. So that helps us to
Yeah.
grade the question.
So currently, the Preksha's elder sister is a biostatistician. So the elbow block test paper, we did a lot of brainstorming over how to prove, and then I agree with you, Ashish, that we need to have someone right from beginning, so that you are on the same track. Then putting data in Excel sheet is easy, and evaluating and writing. But the first thing is design of study and the objects we need to include. That is very important. So that it cannot be questioned, on any platform. That is very important. Great, Jayan. Thank you for your time. Ashish, thank you as always. And
Thank
we'll
you.
meet next week with something more interesting.
Great.
Take care.
Thank you
Bye-bye.
so much.
Bye.
Thank you.
Bye.
Everyone.